These are the standard performance measures for upper GI endoscopy. These are key performance measures, as I told you, fasting instructions and all. And there is one CTL protocol which is followed in the diagnosing the Barrett's esophagus. And the minor performance measures is the duration. They suggest minimum of 7 minutes procedure is required for the first upper GI endoscopy. And if there is any circumferential Barrett's is noted, for every 1 centimeter, minimum 1 minute observation is needed. And during that, we need to follow the MAPS protocol also. So, according to SSR protocol, the duration is, the advice is not inferior to the 12 minutes, and the careful vision of the gastric lumen and acquisition of 22 pictures, almost 12 images in the antegrade and 10 images in the retrovision is advised. In spite of following all these protocols, the minimal changes always the chance of missing in the conventional white line endoscopy. So, to enhance the diagnosis, so they combined with other imaging modalities. We'll call it as image enhanced endoscopy. It's of two types. One is dye based, the other is equipment based, and the third is endosono. The dye based is called chromoendoscopy, and the equipment based is called as narrowband imaging. So what we do in chromoendoscopy is just spraying of 0.1% indigo caramine through the forceps channel across the mucosa, because this highlights the subtle differences between the normal mucosa and the cancerous lesion. So the early gastric cancer is diagnosed when it is compared to the surrounding mucosa. So it has to be spread all over the mucosa. And combining with acetic acid increases its sensitivity, which is proven in multivariate analysis by Kona and colleagues. So these are the different pictures. The first picture is the conventional white line endoscopy, and the other two pictures are chromoendoscopy. One is with acetic acid, the other is with indigo caramine. Coming to the narrowband imaging, the principle here is illuminate the blue and green narrowband lights. So to identify the superficial structure and the vascular architecture. So based on these two, the EO et al. Has classified into various classification system, that is microvascular changes and the micro surface pattern changes. So these are the pictures which is showing narrowband imaging. There is clear-cut demarcation between the normal mucosa and the cancerous lesion. Coming to the endoscopic ultrasonography, endosono, it basically used in the preoperative invasion depth, because endoscopy is always subjective to regarding the assessment of the depth. Endosono gives an objective evidence of the accurate depth of involvement. So normally the main objective of endosono in early gastric cancer is whether determine whether the patient can undergo endoscopy or surgery. So there are two types of miniature probes are available, 20 megahertz and 12 megahertz. Coming to the serum markers, conventional serum markers like CEA, CA99, CA125, they have very limited roles because of the low sensitivity and specificity. So they are pipeline research, other novel biomarkers. One of the most studied biomarkers is pepsinogen, that is serum pepsinogen 1 and pepsinogen 2. So both levels usually increase when there is a gastritis, but when it is changing to malignancy, the ratio decreases. There is one method which is introduced by Fukuda et al., the ABC method. So it combines the IgG levels, H. pylori, and the pepsinogen levels. So it has classified the risk categories into ABC depending on the positive and negative status of the three biomarkers. So this ABC classification correctly stratifies the patient according to the risk of the gastric cancer. The another biomarker which is studied is in atrophic gastritis, gastrin 17. So Chappell et al. Has introduced one gastro panel combining the pepsinogens, G17 and HP serology. This sensitivity specificity is almost more than 90%. The recently biomarkers have been studied in DNA and RNA. So they help in assessing the prognosis, tumor burden, and any residual disease, and predicting the therapeutic resistance. For example, a specific mRNA, that is 1229 3P, correlated to higher risk of 5FU resistance, which will help in treatment guidelines. But overall, up to now, these biomarkers have very limited role. So to summarize, early gastric cancer, the definition is only to mucosa and submucosa, irrespective of the lymph node status. Main diagnostic modality will be image enhanced by doing chromoendoscopy. If you are planning for endoscopic resection like ESD and EMR, endosono will be helpful. The biomarkers are very limited role in diagnosing. Thanks a lot.